Welcome everyone to our panel discussion tonight. I am really looking forward to this, and I think there are three phenomenal women here on this panel that you will just enjoy hearing all that they have to say. So let me just start with some introductions so you know a little bit about them, and then we'll go into the discussion about racism in this country and health inequities and how COVID has actually really exposed them as if they weren't exposed before, but they made it impossible for anyone to deny them now. But let me start with introducing Dr. Linda Ray Murray, who I have known since medical school. But she recently retired in about 2018 after about 40 years of being a clinician. She was a primary care physician, and she was also an occupational medicine physician. But she has been a public health activist for many, many years. She was the bureau chief for the Chicago Board of Health under Mayor Washington here in Chicago in the mid-'80s. She then became the medical director for a federally qualified healthcare clinic and the Cabrini Green projects here on the north side in Chicago. She was also the chief medical officer of the Cook County Department of Public Health until 2014. She is past president of the American Public Health Association and a recipient of multiple awards. She is still teaching as an adjunct assistant professor at the University of Illinois School of Public Health. Welcome, Dr. Murray.
Hello, everyone.
Okay, next I'm going to introduce Dr. Claudia Fagan, who is a past president and currently the national coordinator for Physicians for National Health Program. In her current and past leadership roles in PNHP, she has appeared on national television and radio programs on behalf of the organization and has testified before congressional committees on a wide range of healthcare issues. She has lectured extensively to both medical and community audiences on healthcare reform in the United States and is the co-author of 2 books. Dr. Fagan is currently working as the Chief Medical Officer for the Cook County Health and Hospital System and John Stroger Jr. Hospital of Cook County. She is president of the Chicago-based Health and Medicine Policy Research Group. And in 2016, Modern Healthcare named Dr. Fagan as one of the 10 minority executives to watch, noticing her achievements in the medical profession and her single-payer activism. Welcome, Dr. Fagan. And last but not least, Dr. Mary Bassett, who I'm so excited that she is here. Dr. Bassett comes with more than 30 years of experience in public health. She has dedicated her career to advancing health equity. She is currently the director of the Francois Xavier Bagnaud, also called FACP, Center for Health and Human Rights at Harvard University, and she is the professor of the practice of health and human rights at the Harvard T.H. Chan School of Public Health. Prior to joining the FACP Center, she served as New York City's Commissioner of Health from 2014 to 2018. She has received many awards and honors, including the prestigious Frank A. Calderon Prize in Public Health and the Kenneth A. Ford Lifetime Achievement Award from Columbia University, and she has been elected to the National Academy of Medicine. Welcome, Dr. Bassett.
It's really a pleasure to be here. I'm in awe of the panel, by the way.
Oh, am I? I'm glad that I could get you all here, but this is going to be a delight. Let me start out just so that I think that we're all aware as physicians, you know, we go by the definition of things. And so I think it's important that we understand the words we're using and what we're talking about. So either of you can respond to this, but when we say structural racism or institutional racism in medicine, what is it that we're talking about? What do we mean by using those words?
I can give it a go, but there really is no formal definition that's been widely accepted. I think the critical definition is the distinction between interpersonal racism, which is the actions of people who hold prejudices on a personal level, and the idea of the kind of racist practices that occur silently because they're baked into the institution. The idea of structural racism extends beyond institutional racism because it invokes the fact that racist policies and beliefs are embedded not only in one institution, like our healthcare delivery system, but across multiple institutions. And also are really entrenched in our culture through a host of cultural beliefs that are produced and reproduced. So together, these ensure that racism persists. I think of structural racism really as the foundation on which interpersonal racism thrives and institutional racism thrives. But the key distinction is between personal prejudice and the actions of institutions that can occur independent of our personal beliefs, whether we're prejudiced or not.
You know, I think what Mary said is critical. I think it's very important. What I usually like to tell people is it depends on what role you think or how you think people stay healthy or get sick. And in public health, we like to talk about the structural factors that really cause disease or cause good health. So when I think of structural racism, it may not appear at first to have anything to do with racism at first. Let me pick an example that we have coming up soon. The Electoral College. The Electoral College of the United States is a profoundly structurally racist entity that has caused us lots of trouble since it was first created. Now, many people would not call that out. So I consider structural racism and capitalism the mold around which everything else in our country is formed. And if we don't understand what that mold looks like and how to break the mold or change the mold, then we're going to be in trouble for many more centuries.
I think that Linda's point is very important in that a lot of people say, well, I'm not racist, but not acknowledging their practices that are inherently tilted against one race or another. And the effect of it is the perpetuation of racist outcomes. So if we're going to talk about the pandemic and how we are adversely affected and how communities of color are adversely affected by the pandemic. And it's really quite predictable if we look at people who, you know, what our response has been and what our expectations are. If we look at, for example, folks who we call essential workers, and I'm not talking about the doctors and nurses, I'm talking about the bus drivers and the street cleaners and the people who serve food, who these are lower wage jobs, and people had to choose between supporting themselves and being able to protect themselves from the virus. And so not acknowledging that we place these folks at greater risk with few protections is part of the reason we're having some of the outcomes we are currently observing. So while we may have a pandemic from a virus now, I would say to you that there's been a pandemic of racism for generations in this country.
Yeah, one of the things too that is unfortunate is once the structure is there, the mechanisms to maintain that structure will change over time. I mean, even if we look at just segregation, we don't need a whites only and a coloreds only sign anymore to maintain segregated facilities. There's different mechanisms now to do that. And we don't even realize how we can become comfortable with segregated facilities. I know with healthcare, they're segregated because of finances. And we wouldn't go to a hospital that said whites only, but we may go to a hospital that has mostly white patients because it's in a community where those are the patients who have insurance and can be admitted there. But getting back to the pandemic and how it just seemed that the media was acting very shocked and surprised when these numbers were coming out. And, you know, a lot of times people of color and people who live in poverty are blamed for their own problems. You know, well, if they ate better, they would be healthier. So it's their fault. And so what is it they're doing that made them get so much COVID? So obviously that's not true, but can you respond?
We like to blame the victims in this country. This country is really big on that. We talk about obesity, and we don't talk about food deserts in terms of what choices or what food we offer people. So we talk about, you know, well, why are those people living together? You know, so how do you expect someone to isolate when you're living in a multi-generational household? And you have to live in a multi-generational household because who has the resources to strike out on their own? And so you expect people to isolate themselves when they're all using a common bathroom, when they have a common place for food preparation, when they're sleeping under this in the same bed, if not in the same room. So it's not surprising that we have the problems we do. What's surprising was the delayed response in trying to come up with solutions to offer alternatives to folks that would allow us to in some way mitigate the exposure that people had.
I think that there's a real tendency to interpret racism as interpersonal racism. So people will talk about, you know, the implicit and explicit bias of doctors, but they won't talk about the way in which our hospital system has become segregated, and the public hospital system, with hospitals often located in poor communities, which are themselves constantly under financial stress. They don't talk about that. They talk about personal behavior, and that extends to what made people vulnerable to COVID. Just as Claudia has said, the first go-to explanation is those people have always been sick, and now they're getting sick again. And it's a real pity we can't help them much. And this was basically what was said by Tony Fauci, who's been a real exemplar of somebody who's been prepared to speak truth to power in some ways. But that was his explanation, and everybody will remember what the Surgeon General did, you know, telling people to stop smoking and drinking and invoking, I guess, his version of Black English to do that. So there's a real tendency to say the problem is in the bodies of people who've gotten sick rather than in the risk of exposure. And Claudia's explained how it could be at home. Linda's explained how it can be at work. And of course, there's also crowded transport to and fro. You know, it's not rocket science, but hardly anything was done to protect people, especially the low-wage workers. Everybody thought essential meant the doctors and nurses, but that was wrong.
And then I think, especially as physicians, we get very lazy, you know, and how we diagnose problems. So we, you know, if we're in urban settings, it's easy for us to talk about the quote comorbidities. But when we look at Washington State, for example, the group with the highest case rate and death rate there are the Asian Pacific Islander community, for the same reasons in New York City, you had Black and Latinx people. It has to do with what kind of exposure they have, what kind of work they have. Probably one of the worst rates for COVID deaths in the country are Native Americans, especially those that live on reservations. So we actually refuse to accept what we understand causes most disease, the social structures that we surround ourselves with. And so then, instead of looking to those places like nursing homes or jails where we can predict we're going to have higher rates of death, we ignore that and pretend to only concentrate on the personal level. For physicians, I really consider this akin to malpractice, or at least laziness.
So what do you think physicians should be doing?
I think we have an obligation. Yes.
Truth to power here.
Yes. I think we have an obligation as clinicians to actually use our diagnostic skills appropriately. I think there's plenty of room for arguments about different emphasis, but the evidence is overwhelming that social structures, and has been for centuries, that social structures and what we create as human beings has the greatest influence on human health. And I think you see this trying to creep into some of the curricular changes in the medical schools. But it's harder, even for physicians with our relative privilege, to attack those complicated social structures. It's much easier to look at somebody sitting across from you half naked in the exam room and point your finger at them and saying you have to exercise more and stop eating fried chicken. That's an easier sell, and most physicians are more comfortable doing that. When the real problem is, what's the food system in the community where you're serving your patients? That's a much more difficult thing to try to change.
Right. So it's a thing that, and Linda, I learned this from you. Everything is health. And so actually, one of the things that we've looked at in Chicago is trying to provide secure housing for folks, recognizing that people who don't have safe, secure housing are more vulnerable, whether they're exposed to COVID or not. So we looked at what they were doing in terms of disaster preparedness in the midst of the pandemic. And they did these unmitigated disasters where they took a convention center and they put thousands of beds, and said, okay, here's to protect you from COVID. And that was not what we needed. What we needed was housing for people who didn't have stable housing. And a lot of our patients who they would have been too sick to go to McCormick Place where they set it up. What they needed was some place that they could be isolated but receive care and have food. And so as physicians, we have to advocate for the things that we know are right. It's not about being able to give a patient medication. It's about being able to make sure a patient has safe food to eat and has a secure place to put their head at night. And so we did this in a number of ways. We actually took a YMCA and made housing for homeless people and had docs who volunteered to provide care for those patients who did not qualify for the hotel rooms, who didn't qualify for the disaster, transitions that they put in the convention center because no one wanted to deal with that population. So as physicians, we have to start talking about the things that we know are important and that are right. And it's not about being able to give a patient a pill. It's about being able to address their personal needs that will allow them to be taken care of.
I think also that physicians shouldn't be shy of speaking about things that are really outside of our lane. I mean, I saw some really creative things happening during the peak of the Massachusetts COVID, at least the first wave, with the one public hospital that's left in the state of Massachusetts negotiating with hotels to give them rooms for hospital staff, negotiating with universities to give them these empty dormitories to put people in who needed to get mid-level care, and developing, all kinds of strategies that kept people home who didn't need to be in the hospital. That was great. But we also need to talk about the fact that people need to have a living wage, that there has to be more affordable housing, that we have an obligation to protect all workers regardless of their status. You need the person who cleans the floor to keep a hospital going, just like you need a doctor. So and we need the people who are doing the deliveries and stocking the grocery shelves, and all the people who've allowed someone like me to stay safe at home. So I think we need to speak out about that, even though we don't have any direct authority, and try to use our position as for what is left of the status of physicians to say that this is what it means to have a healthy society.
It sounds, all three of you are, saying that, it's really changing the focus of healthcare from that doctor-patient to more of a public health, because one person may be very healthy, but if everyone around them isn't, nobody's healthy because everyone is in the same pool. So what should we expect from public health? Besides being funded appropriately, because the public health system in this country has been decimated, but what should we expect from them to help us kind of address this? Because as a physician, we are often aware of what social services our patients could benefit from, but there's no way for them to access those services, either because they're not there to be given to them, or there's not enough people to provide for the number of people who need, or, you know, it's a myriad of problems. But should we put more focus on public health?
I work in public health, so that was my solution to what I witnessed as a clinician. But I really think that public health, first of all, I can't say something about public health without saying that it's been under incredible attack in this period. And you all have heard about the departure of leadership from Milwaukee, for example, first jurisdiction to declare racism a public health crisis, first jurisdiction to note the excess of African Americans among people dying of COVID. The health commissioner has decamped to, I forget where, I think a foundation or something. I was just saying that she couldn't do her job in Milwaukee. Other commissioners have faced death threats, and I mean, over wearing masks. So I just want to say that it's been a really bad time for public health, and part of it is that they were asked to respond with too little funding. But the answer of what public health should be doing has to go beyond telling people to wash their hands, put on their masks, and cooperate and participate in contact tracing, and, you know, stay away from people. That is much too narrow a framing of what an appropriate public health response should be.
Yeah, I think that we have to make a distinction between public health, broadly speaking, as part of the health sector, and governmental public health. And all of us who have worked in the public sector, and certainly those of us who worked in governmental public health, has seen the actual day-to-day tension between our politicians, regardless of their particular party, and what we often think is necessary. That's the nature of governmental public health. I think that I have to say right now that I am really enraged and heartbroken over what state we find ourselves in the United States in terms of governmental public health, where you have previous CDC directors writing public letters complaining about the role and activities of CDC, where the pressures on as Mary mentioned, on state and local health officials is so tremendous, and where people are getting, you know, from Dr. Fauci down to some poor county health officer are getting death threats over whether they think they want to put out a mandate asking people to wear masks. But regardless of that, I think that the strength of public health is that you have to become allies with everything else that's going on. If we look at the history of the United States, when public health activists and leaders have allied themselves with social movements, whether it's women's suffrage or the right to unionize or the progressive era in general, when we've united with social movements of the time, then we've been able to make great strides and work as allies. When we've tried to divorce ourselves from social movements and try to pretend like we're neutral, then we slide backwards. And so to me, we know what needs to happen in this country. This pandemic is not going to be dealt with in the world, and certainly not in this country, without really addressing underlying problems. Why is it most hourly workers in this country don't have paid sick leave? How can we effectively address seasonal flu if we don't have paid sick leave for most people? So these are structural things that we have to change. Are we surprised that if you have a class of 40, 45 third graders, that you're not in a good position to run that class during a pandemic? Well, we should never have a class of 45 third graders to begin with. We should have a class of 10 third graders, maybe 12. So we have to begin to argue for what we know really impacts people's health.
Let me ask this about our safety net hospitals, because they have really been hit hard by this pandemic, with so many people getting sick, who often have no source of funding for their health care. Dr. Fagan, let me address that to you, since you're running one of the largest public health safety net hospitals in the country. What have you seen, and what are the particular problems that you've been facing?
Well, I mean, I think the challenges we're facing are the challenges that actually turns out that all hospitals are facing with the advent of COVID. There's a problem with funding. And, so it only, the difference is we're used to struggling with funding, whereas other hospitals may not be used to it because they had to stop having elective surgeries, which is a source of revenue for them. A lot of hospitals and governments, because we had everything shut down, they had decreased funding because of the less tax revenue. People weren't going out and aren't spending money. And so what happens is, trying to do less with more. One of my favorite lines from one of our commissioners, after a joint commission survey, and the surveyor was marveling at all the things we were able to accomplish with our limited resources. And the commissioner said, yeah, that's our problem. He said, we keep doing more and more with less and less, and pretty soon people think we can do anything with nothing. And so what we have seen is that patients are afraid to come to the hospital. And when they do come, they're sick. And with COVID, they can deteriorate very quickly. And it's marshaling enough resources to make sure that we can take care of those patients. I don't think we're different from any other hospital. We turned, of the 8 critical care units, I think 6 of them became COVID units. We converted our med-surg floors to COVID floors. We had to spend a lot of time and effort with our staff showing them about PPE and making sure they had what they needed. But we're paying the price now because we're trying to look at our budget for next year, and we're going to have to cut services. And why would a public system cut services in the midst of a pandemic? Because we don't have the resources. There's a finite number of dollars, and we have to be able to take care of as many people as possible. But at the end of the day, we have to meet our payroll. We have to pay our bills. And no one's coming in with, we received some CARES dollars, which helped us, but this is an ongoing thing. And so what we have to look at is, what are we not going to be able to do in the coming year as a result of the funds we've had to spend for COVID? And these are painful decisions.
Yeah, did either of you want to comment on that? Or because all hospitals, like you said, are having issues now. And so what do you see as more and more hospitals are closing now? I know here on the south side in Chicago, Mercy Hospital is going to be closing in a few months.
So I remember in the 80s, we lost 11 hospitals in a single year. And I expect that although Mercy, which is a 400-bed hospital, has been around for over 100 years, it has announced that they plan to close sometime between February and May of next year. I think that will be the first of at least a half dozen hospitals that are on the bubble, and that the cost of COVID kind of pushes them one way. They may have been tilting that way all along. And I think that the answer to this is as we watch hospitals closing, the question becomes access. And if you talk about what we need at this point, we may not need all those hospitals, but we do need access to care. And we need to look carefully at our healthcare delivery model. We need to deliver people care in the communities where they are, because they're more likely to access it there. And we have to be more creative in terms of looking at our delivery model, because our delivery model for healthcare is based on things that happened 50 and 60 and 100 years ago. And it's not that we need so many hospitals, but people need access to information. They need access to care. And we are stuck in, I don't want to say stuck on stupid, but we're stuck in an old delivery model that's not meeting the needs of the communities we're trying to serve. And I actually think of this as an opportunity to be a little bit more creative and innovative in terms of what we do decide. And I think that's one of the things that public health has to help us with, is that people need access to things that they're not getting access to right now. And we need to look at some alternative ways. One of the things that people worry about with hospitals, because hospitals are often the economic engines for a community, and that shouldn't be. We shouldn't be dependent upon the hospital to provide the jobs, but in a lot of communities, especially poor communities of color, those are the jobs that people get. And so how do we address the bigger problem in terms of the poverty, the lack of a living wage, and also how do we provide people with access to the information to take care of themselves, as well as to access to the providers, to, you know, whether it's community health workers or, you know, people who can provide folks with information that will result in better outcomes for us. I'll start with that.
Claudia, I mean, when you have a new virus that spreads through the air, that, you know, the initial appearance of these huge racial disparities with the age-adjusted death rate 3.6-fold higher for African Americans than for whites, for example, and some age groups ranging as high as 7-fold higher among young people. You know, I don't know how, you know, there isn't much treatment. People didn't know how to prevent it. I mean, how do you think you need access to hospital beds when you have a pandemic that results in potentially lethal?
There's no question that you need access to hospital beds, but some of these hospitals, for example, if you look at Mercy, which is a 400-bed hospital, and it's running an average daily census of something like 80 over the past year. So a lot, you know, so a lot of these.
This is one of those poor, in New York, there are a lot of, it's a safety net hospitals that are private, are effectively private. I forget what we call them in New York, we call them voluntaries because there are no for-profit hospitals.
Right.
But they play the role of safety net hospitals.
That's exactly right. And we have
they're very, very vulnerable. Yeah.
And so, you know, they need access to hospital beds, but people also need access to understand what sort of things they can do. You know, we haven't, there's a lot of misinformation out there about what people should be doing. You know, we first told people not to wear a mask, and then we told them to wear a mask, and really helping them understand why that's helpful. And, you know,
I mean, you can't blame people, right? I mean, look at the astounding levels of disinformation that are emanating from, you know, the highest office in the land. So it's understandable that people are confused, but this is way outside of my expertise, but it just seems to me that hospital care shouldn't be as expensive as it's become. I don't quite understand it.
You know, we have a medical system that's designed to make profits, and that's what it does for some small group of people. But in addition to, obviously, you know, in my mind, a single payer health plan should be in the first 100 days of hopefully a new administration. The first 100 days, not the first, you know, term, the first 100 days. But more importantly, along with the financing mechanism that makes more sense, we need to have planning, health planning. So, for example, there are about 3,000 counties in the United States. Only half of them have even one ICU bed. So when we talk about a medical infrastructure, it doesn't exist. And we know with seasonal flu, that the death rate goes up depending on the smaller the community is, so that the rural hospitals have higher death rates than urban hospitals, for example, because we don't have a rational way to put resources where they could easily be accessible to people, and we don't have a rational way to transfer people if they need a higher level of more complicated care. But until we address the problem of our medical system thinking it's designed to make some people profits, then we're going to have absurd bills and expensive care and not really provide the kind of care that we need to provide. So actually we do very poorly as a nation in terms of providing medical care to our population.
Rural hospitals must also be in trouble, these small
Absolutely.
rural hospitals.
They are in trouble. And these hospitals, what they profit on are surgery, right? They profit on these elective surgeries, but they aren't equipped by what people needed in the midst of this pandemic. They needed critical care. They needed to have folks who could, you know, take care, you know, pay attention to their oxygenation levels. You know, they didn't have the doctors or the resources to provide the things that people needed most immediately. You know, we talked about the need, patients did better when they were prone. Having enough staff to prone a patient, turn a patient over so that they could breathe better on their stomach as opposed to on their back, you know, that required a huge lift from a lot of places that were not able to do it. We struggle with that. So having the hospital bed, that's a good thing, but there's a lot more that's required. And it's not that we necessarily have the hospital beds. When we talk about losing hospital, we don't necessarily have them where we need them. We have where they were profitable to be. And so that's one of the things that we struggle with a great deal right now.
I have more questions, but I'm a panelist. I'm not sure I should ask. But
You could ask questions, Mary.
Okay. But it seems to me that we shouldn't let this discussion go too far without noting the confusion that resulted from the messages about public charge and people being really frightened about, what using services, even if they were entitled to them, might mean for their path to citizenship. And also, just in general, you mentioned people being afraid to come to hospital. And I read a paper from LA, I forget, it might have been the Kaiser system, which I think is sort of like a single payer system. I'm not quite sure, but the bulk of their Black patients were getting tested in the hospital. So in other words, close to their diagnosis. And as opposed to getting tested in testing sites or whatever. So that also implied this sort of late care seeking. And I agree that fear is part of it. What do you think is going on there?
So we did, that's a large segment of the population. We deal with a lot of undocumented folks, and folks were terrified that seeking care would somehow jeopardize their future status. And we had to, this has been an issue since the beginning of the Trump presidency in terms of people feeling afraid to even come to get care, that they would somehow or getting care for their children. And they would have children who are US citizens who were born in this country, and they'd be afraid to come and bring them to get their immunization. So this has had a terrifying effect on the population in terms of folks being afraid to come out, being afraid that if they came, that ICE agents would somehow have access to their records, or that they would be taken away if they came into the clinic. So this was bad even before the pandemic. And so the misinformation out there has made it very challenging to make sure that people are aware of what they're entitled to and how to get what they need. It's required a lot of extra work, a heavy lift in terms of getting information to people who need it the most.
Well, clearly, I think the financing of our health system now, which is for profit, and it places services where a profit can be made versus placing services where it is needed to provide care where it's needed. So there's this disconnect, and it's all driven by money. And so that it's not surprising that we end up with these deserts and these gaps in care. So how should we, address the structural racism? I mean, I'm a Medicare for All supporter, and to me that would help really address the access issue a lot. It doesn't necessarily solve the social determinants of health, but right now with our current financing system, poor people are the ones that no one wants to take care of.
Right. Yeah, as Linda said, that's just the first step.
Yeah.
What that does is it kind of levels the playing field. And what I would say is that providing access and a Medicare for all is important, because we in this country access to care is insurance. If you don't have insurance, you don't necessarily have access. And certainly don't readily have access. But then the conversation has to become about what we're delivering or what you're getting with that access. And I think that's one of our biggest challenges, is that the failure to address the social determinants of health that are so important in providing people with good health.
I also was just struck when I was looking at the states that declined Medicaid expansion, and the bulk of them, not all of them, but the bulk of them are in the South, and that's where the bulk of the Black population in this country still resides. so that you're much more likely, if you're, live in the United States or African American, to live in a state where the eligibility is for Medicaid is much more stringent, leaving a much bigger gap of people who are too poor to be eligible for the very inadequate service, coverage offered by the Affordable Care Act. Too rich to be too poor. Which way have I got it? No, they're above the cutoff for Medicaid, but below 100% poverty, which would make them eligible for under the Affordable Care Act. So, that's a structural, getting back to our theme this evening, that's really a structural thing that the Southern states have a tendency to be much more conservative, and the Black population that lives there suffers for it.
But I think
everybody suffers for it. Right. I just don't understand this country. I really, I just can't figure why there's such resistance to what every other Western democracy has figured out how to do. Why people don't think that everybody deserves to have healthcare access. And in the midst of a pandemic, what better time to see the disaster that results from people losing their jobs and they're losing their health insurance.
So I think so let me just put another burden on everybody, not obviously physicians, but certainly everyone else. We really have to have a better understanding of history if we're going to untangle these structural problems. So for example, when we look at health inequities, and we don't have these numbers for all groups, all people of color, but we do have it for Blacks. There's a recent conservatively poll study, not conservative politics, but carefully done study that argues that about almost 8 million excess deaths have occurred among Blacks from 1900 to 1999 if we had had the same death rates that whites had. Okay, that's a huge number over 100 years. And when you think about how we structure our healthcare, so if we had a healthcare workforce that reflects the population. So one reason people are hesitant, for example, during the pandemic, I know many people, many African Americans who had insurance, but were afraid to go to the hospitals because they were afraid of what was going to happen to them in the hospitals. They were going to be separated from their families, etc. What if we, in fact, structured a healthcare workforce where we paid attention to people's needs? People in nursing homes, and we had people who could actually call the family and arrange for that communication in crisis like this. It's not simply that we don't have a good financing mechanism, though Lord knows we don't have that. It's that we really have not put a value where it needs to be put on human beings and human experience. If we did that, I think we would be in a much better shape for all of our folks. But that means really addressing that structural part of the mold. It means breaking apart our present mold, really challenging whether we need capitalism. I don't think we do, but that has to be a question on the table. Otherwise, we're going to be spinning our wheels. This pandemic is putting in jeopardy everything, not just in healthcare. It's look at our supply lines, how we get medicines. Most of the medicines we take, all of my medicines that I take, came from abroad, from India and China. So there was some real question early in the pandemic: was that supply going to be stable? We have to begin to look at the entire society and how all of these issues are connected, because they are connected, so that we can begin to systematically address the problem. Housing, education, employment. In Germany, for example, I have a niece that lives in Germany. Those German workers, regardless of where they said, they got 90% of their pay when the pandemic struck. So you didn't have people being evicted for rent. You didn't have people not being able to get food. I mean, here in Chicago, our children, so many of our children get their food from the school system. So when the schools are closed, they're not getting food. We've tried to make emergency arrangements, but still many of them are not getting this important food. We shouldn't have a system where children have to go to school to get fed.
So it's not, I think, Mary, one of the problems is that the majority of people in this country don't understand that we already spend enough money on healthcare in this country, but we allow too many people who are not engaged in the delivery of healthcare take profit from it. That, people always, they think we can't afford to provide this care, but we're spending the money. We're spending more than any other country in the world per capita on healthcare. And yet we're leaving a third of the population either uninsured or underinsured. And the consequences of that is that the care that when people do get care, it's far more expensive because they present with more advanced disease and with greater need, and worse outcomes. Until we begin to address those, that disparity, so tell me why a Black woman with a college degree has a poorer outcome with breast cancer than a white woman who's a high school dropout. Until we begin to look at those, down to that level, we are not going to address the needs of our population. And as a system, we have failed. We're failing the population because we're spending the money and yet not getting the outcomes we deserve or we should have.
We're spending the money in the public sector that could, pay for Medicare for all.
Yeah.
So it just, really, there has to be a move to take profit out of healthcare. Nobody says that a fire department should be self-supporting and should, it's just a framing that also opens us to poor quality care. Because its goal is not to deliver what's needed or appropriate, but to deliver what will result in profits. So that means that people have both too little and too much care.
And this brings us back. I want to quote
Okay.
Rahm for a moment. Our last mayor, Mayor Rahm Emanuel, don't let him come back in this new administration. He is quoted as saying to the head of the teachers union that he didn't want to spend more money on the Chicago public schools because a quarter of those kids weren't worth spending money on. They weren't going anywhere and there was no need to spend money on them. So we should come back to this. One of the reasons why our medical care system doesn't take care of people is because the people that run this country don't believe that huge portions of the American people are worth taking care of. That's the only explanation. And yes, people of color, Blacks and Latinx and Native Americans, yes, we are at the top of that don't care list. But the reality is, if the leaders of this country don't believe the American people are worth taking care of, are worth having basic human rights, then we have to change leaders. And I don't just mean by voting. We really have to change the institutions and the structures that control this country if we want to change that equation.
Well, there's been a couple of questions that are kind of related to what's being discussed here. But what should physicians and nurses and PAs, other people who work directly providing healthcare, what should they be required to demonstrate knowledge of some of the racism in medicine and healthcare delivery? And also, what role can these healthcare workers have fighting budget cuts that harm the community in the immediately versus long term?
There's a lot to.
Everybody needs to learn more history. You go first, Claudia.
I'm gonna say, so we are as a public entity, we're required by statute to present a balanced budget. Now, how is it you expect to take care of people who are unfunded and yet, balance the budget? There has to be resources. There has to be a commitment that we're going to take care of the population. When you have a law like that requires me to come up with a balanced budget in the midst of a pandemic, you're going to force me to cut services. And so, that's just like a backward approach to a problem that's much larger than us. And so I think that there has not been a commitment to provide people to spend the dollars where they're needed to deliver the health care.
On the question that was in the Q&A about should physicians and should clinical workers be forced to prove some knowledge about racism as part of the licensing queue. A few years ago, some states did require some superficial and poorly done education on implicit bias. I'm not against that, but that doesn't solve the problem. These are structural problems that are not going to be solved by people's attitude. Do I think physicians and nurses and PAs and pharmacists and janitors should have basic education about how this country works and what the history of the country is? Yeah, and that should start in elementary school. So if we stop lying to our children as part of their education, that would help. It won't help immediately, obviously, but it would help. I do think that our health profession schools should have curriculums that accurately reflect what the history of medicine has been in this country and what's going on and what makes people sick and what makes people healthy. That's a struggle. And usually the students are in the leadership of that struggle. I know that's certainly the case right now. We're in Chicago, most of the medical schools in our area, we have active students fighting with the administration, trying to put some anti-racism curriculum in the coursework that they have. But we can't afford to wait until everybody's educated. We have to begin to change things. And I'm less worried about exactly what gets changed. I'm more worried about the fact that nothing may change. So at this point, my attitude is change as much as we can, as quickly as we can, because when we're slow, people die.
That is definitely. So how do we advocate for our patients? I mean, this is just a trying time where the needs are just so great and the resources to meet these needs are so scarce. So someone asked, how do we advocate for our patients to help them get what they need?
Well,
Individual basis or broadly?
Well, that was what the question asked. I think it was individually because the question referred to our patients. So,
well, you know, our patients need more than like I said earlier, than what we're delivering, and we have a right to remind the politicians that they work for us and that there are needs that are not being met. And so, you know, it's ridiculous that Congress is not able to allocate the resources. You know, they're in a pissing contest between the Democrats and Republicans, and the losers are the American public. So I think that we have to demand more of our elected officials, that they have to be responsive to the needs. The people are dying and people are losing their homes and people don't have enough to eat and they're suffering the consequences of poor planning. And so as physicians, we have a voice and we have to speak up for things that we see that are wrong and not pretend that it's okay and not just go along to get along. I mean, that's hard to do. People say, well, that's not why I went to medical school. But if you want to take care of patients, then part of it is using your voice and advocating. And quite frankly, the way our society is, physicians do have a voice that's heard over the din of a lot of others.
When, before I took this job at Harvard, I was the health commissioner for New York City, and every year the health commissioner puts out at the end of the year 10 things you can do to be healthy, and or something like that. And this is something that's done all over the place. And some people in the UK, it says things like don't smoke, don't eat too much, don't drink too much, don't drive when you've been drinking, stuff like that. So some people in the UK did a send up of these lists, and they said, don't be poor. If you have to be poor, don't be poor for long. But anyway, there were things like that. But the one that seemed practical to me in the immediate sense, because all of that was good advice, was claim all your benefits. And I think that that we, when you have contact tracing, that person shouldn't only be looking to find out who you've been around. They should be making sure that you know about the services that are available to you for food aid, for housing aid, that we need to try and build in to our work the idea that we're responsible for letting people know the benefits that are available to them. And I think that's practical and could be implemented much more widely than it is.
I would hope that physicians would stop being advocates. That's a word I have never liked, and join the fight. So there's a big distinction. You can, if you're an advocate, that's like you're handing out charity or getting some charity for your patients. what we need to do is fight for change in this country and fight for basic social justice. Now, we can do that on an individual level when we have a patient in front of us. And you know, we used to have tools that helped us in the county system find, you know, food pantries and things like that. I'm not against that kind of individual level getting resources to the right people. But the role of us as healthcare workers, if we want to really fulfill our role, is to fight for changes in the society that we think will help people stay healthy. And that's where I'd like to see us put our energy. And that means being part and parcel of all the debates and struggles that are going on now in the streets, and trying to lend our particular view. So for example, when I'm dealing with young people who are trying to defund the police and the like, and I say, yeah, that's cool, but don't forget, more people die from diseases that this society gives them every year than the police kill. So while we defund the police, we also need to do other things that are just as critical to keep people alive and keep them healthy.
One last question. What about our senior population? Because they are especially hard hit because of their age, and many are in long-term care facilities, and they often may not have individuals to help them to do things. What should we be trying to address to help them with those issues? Because again, it's systemic. I mean, it's the fact that we don't have these resources, that it hasn't been a priority to take care of children. We don't feed them unless they go to school, like you said. And with older people, you know, we just put them away and hope they're okay.
Well, no, it's unfortunately we've decided to warehouse our seniors in congregate living facilities where they were set up, where they were so vulnerable. If we had appropriate funding and we had appropriate structure, more of these people would have been allowed to be taken care of in their homes, where they can remain and do better for longer if they are provided with in-home care. But it's not something that we make generally available to seniors. So now that we have warehoused them in these facilities without appropriate protection, I think now we've learned a lot about what they need in terms of protection, and recognize that people who come and go every day are a potential threat to them, because there's a risk that they will bring the virus to them, and they're sitting ducks and they can't protect themselves. But we need to value our elders more than we do as a society, and not just toss them away when they need more assistance and help. And we need to advocate for a system that provides more opportunity for them to be taken care of in their natural setting in their homes, because we know that as dementia sets in, disrupting them by putting them in a whole new setting just hastens their deterioration. So it's something that we have done for expediency as opposed to what was in the best interest of the patients we were trying to serve.
And specifically to COVID, it's clear that the larger for-profit nursing homes were a bigger problem in terms of risk to patients. And of course, the fact that the people who work in them were paid such low wages, that they often work in multiple institutions to patch together a living wage, made them much more likely to be carrying COVID from one place to another. They also died, healthcare workers in nursing homes. And last, there were some unwise decisions made to send older people back to nursing homes when they were sick with COVID, and reintroduce COVID with hospital transfers. So that I think, we should speak out against. That was dangerous and shouldn't have happened.
Well, there's sort of a common theme: older people, people who were incarcerated, the group of people that no one seems to care about. We keep them in an environment that we clearly know is not healthy or appropriate, but that's what was done. And there wasn't there didn't seem to be, at least in the media, oh, this is wrong, but there wasn't this horrendous outcry to that. There wasn't this is abhorrent. You know, I never got that feeling that people in this country really felt that it was as bad as it really was.
Right.
And I mean, it just speaks to sort of, you know, the culture here.
Well, that when old people die, it doesn't really matter as much.
Yeah, they've served their purpose or whatever. Yeah, it's just
So,
cruel.
Well, this old person thinks that's absurd, of course, but also I think we have to be careful here. I think, Dr. Rogers, that people are upset. I think people in this country are angry. The problem is that they're angry for different reasons and they're confused. Frankly, that's how we got President Trump. And that's how we get such a low turnout to vote, because people are presented with choices that don't seem to have answers. And so to me, the big question is, how do we organize that anger of people that live in this country to come to a sort of a common understanding, and I think a more accurate understanding of where the problem is. The problem is not some new immigrant from Honduras. The problem is not some 16-year-old black boy running down the street going for a jog, or you know, the problem rests with people who run the country. And so one of the tasks we can do as physicians is to help make that clear to people and help talk about the structural issues like we've been talking about tonight that cause these problems, that are the reason why people are evicted or why the people are unemployed, just because we have a new novel virus running around. We're the richest country on the planet, and there's absolutely no reason why anybody in this country should be homeless to begin with, but certainly not made homeless because of a pandemic. So I think that physicians have an obligation, and everyone in healthcare, every period, but certainly those of us that are privileged to work in the health sector have an obligation to draw a line between what people are angry about that they see in the streets and they're rightfully upset to what the causes really are.
Well, it speaks to what Mary was talking about before, about the history of this country isn't known. And you know, that's why it's easy to blame poor people for being poor. You know, if you don't understand why they're poor, you know, or why, you know, so many 25% of Black people in this country, you know, are poor. And, you know, I mean, it's just the numbers are kind of mind-boggling, but people don't know the reason why. And it's hard to fix something if you don't know why it's there, because you don't know how to treat the underlying cause. But I'd like to give each panelist an opportunity to say some closing remarks before we end this. And I'd like to thank the three of you for joining me tonight, and to all the attendees who tuned in and listened to this. So would you like to make some closing remarks here, or?
I was going to say something that Linda will tell me is much too narrow-minded and you know, it's not enough to the barricades. But speaking of older people, one issue that's come up and the upcoming election is that poll workers are older, and they shouldn't be out there probably. So all of us who know young people who are looking around for something to do, we need to encourage some younger people to volunteer as poll workers and make sure that the polls all remain open, because if there are fewer polling places, that's another reason that makes it less convenient for people to vote. So I thought I would end with that plug. Since all of us are looking for small sometimes, but practical things to do. But I couldn't be more in awe of both Dr. Fagan and Dr. Murray, who I've looked up to for many years, and model what it means to be physician activists.
Well, let me endorse what Dr. Bassett was just saying for a moment, that we do need people to watch the polls. And I'm going to quote Sir Michael Marabout. He said, if you're not doing anything, do something. And if you're doing something, do more. So all of this starts with one step. So if you're not doing anything, do something. And if each day you do more than you did the day before, at some point we will be storming the barricades.
I think that I'd like to end and I appreciate that if you're not doing anything, do something. That we have to take care of each other. And we have to, this has really taught us that we need to look out for one another and not be afraid to ask the person next to you if they're doing okay. Because these are very challenging times. And it's really through supporting each other and supporting our community that we'll be successful and persevere and prevail ultimately. So I think that young people, yeah, it's great that we need them to be poll watchers, but we also need them to be willing to go to the grocery store or willing to do that extra little something for someone. They'll feel better for it and we all will be richer for it. And I'll stop there. Thank you.
Wonderful.
And thank you, Susan, Dr. Rogers, for
Yeah, I totally enjoyed. And like I said, I appreciate the panelists for joining me here tonight and to all the attendees who listened to us, and hope everyone enjoys the rest of their evening. And you can go online and become a poll watcher. Now, I signed up to be a poll watcher, and even though I'm in age denial, they told me I was old, but I'm in denial. But the way I look at it is that I can do more for my grandson by being at that poll, even if I suffer from COVID for doing it. It's a, you know, we take a risk, but, you know, I don't want him to grow up still being afraid of the police in 10 years from now. That's more important to me. We all have to make our choices. We all have our level of risk that we're willing to take, but, you know, if you can't go, get somebody else to go. So.
Everybody vote.
That's the other. I will early vote.
And hopefully one day, Mary and Claudia, I'll see you actually in person instead of over the Zoom nonsense.
yeah.
Okay. Good night, everyone.
Good night.
Okay.